top answers here would allow you to say non-pathological. So I heard you use the terminology non-pathological. We have to quantify that. I mean, it's logical. What are you looking at to actually make that clinical judgment? Yeah. It's not clinically significant. It does not impair functioning, or it does not result in clinically significant distress. That's bereavement. Now, of course, we'd evaluate for a major depressive episode. Remember, inherent in a major depressive episode is the same criteria. That is, it must be clinically significant, and if it's not, it's bereavement. Okay, so and that would be the prequel. What then do you think is going on in this film when it comes to her dysphoria? I heard pathological bereavement or pathological grief, but that's not a diagnosis. So playing charades. Exactly, and the APA made it very difficult for us. It's a 4-part term now. Pathological grief would have been much better. I guess they wanted to make it so that third-year clerk could easily identify in an exam. That's exactly what's going on here, at least, right? So we see that the dysphoria that this particular character demonstrates is pathological, is clinically significant. Okay, and as part of that evaluation, as part of our watching this movie and providing a case discussion, we have to consider a major depressive episode too. Right now, in film, they usually are not going to contain all 5. I don't know if Wes Craven knew there would be 5 criteria. Do we think Sidney Prescott is depressed?
I think probably.
Yeah, especially if, remember, we chose to go down the path we are, and that we're thinking that everything that's going on in this movie is a product of her mind. Because it would be very tough to explain her psychosis and say that she's not depressed, right? So this looks like that is Scream. The film looks to be a case study, a fictional case of major depressive disorder, severe with psychotic features. So Sidney presents to clinical care. You evaluate and provide this diagnosis, discuss with the patient, plus or minus family, social support, hopefully not Billy. Your treatment planning, which would be biopsychosocial, certainly brief counseling, one-on-one psychotherapy, and now you're going to talk medications. On your shelf exam, what medication here would be indicated? SSRI, so you're going to go with antidepressant. What percentage of individuals provided antidepressant therapy, monotherapy, would improve with this condition? Close, 30%. 30%. So what other medication would you consider? Right. Now, if provided an antipsychotic monotherapy, what percentage of individuals with this condition would improve? So what percentage are you guessing here? 30%. 30%.
For depressants.
All symptoms. Sidney getting better in the sequel. Now we're provided both the antidepressant plus the antipsychotic. Now what percentage of people?
60.
70%. We're gonna. You're within. Yeah, you are some synergy there. You're within a 10% margin of error. So you're right. And as you're looking at the combination, so choice A is going to be an antipsychotic, choice B is going to be the antipsychotic antidepressant combination. But you're going to read further because choice D will be your single best answer. And what would that be?
All 3.
Yeah. Yeah. Electroconvulsive therapy, major depressive disorder with psychotic features is 90%. 90%. With less side effects. So you're not going to withhold that from the patient. Even though certain correspondences this morning in our blue room suggested otherwise. All right, so that's Sidney. Again, this would be the biological or somatic treatments, and as part of our comprehensive biopsychosocial plan, which would include psychotherapy, grief counseling. I think that's very fair. Anything else with Sydney here?
Maybe some elements of PTSD.
Yeah.
Trauma, yeah.
Yeah, no doubt about it. And I think that would be picked up. I don't know if our treatment, our medical management would differ all that much. I think you might want to just double check to make sure that the SSRI you choose as part of our regimen is also FDA approved for post-traumatic stress disorder. But beyond that, I think communication with a therapist to make sure that we're all on the same page is sufficient here.
Is her like running away during these potential delusions? Like wanders into nowhere half the time when she's being chased by these things that aren't there.
So it doesn't happen universally, but very often individuals who do have dissociative episodes in which they run away or travel tend to assume, they're not, again, does not have to be in place, but tend to assume a new identity. And I'm not sure that's happening. Although, I would certainly inquire. By the way, how does the assumption of that new identity, just to go off on a bit of a tangent here, differ from the diagnosis of DID? Fugue.
State.
So yeah, with dissociative amnesia with fugue, with the fugue state specifically hallmarked by a change in identity. How does that actually differ from dissociative identity disorder?
Like you have like almost a separate identity.
You're on the right track.
Or you dissociate.
Well, you're getting dissociation in both conditions.
Are you saying for the fugue state, did you say that's with a different identity? Like that's a separate diagnosis from just regular fugue state? Or
Often
No.
in fugue, people will go to wherever they're going,
Yeah, and they forget.
a whole new person. They're like, I am a different person.
That usually associated with like an acute traumatic event, where DID might be like
No,
chronic.
there's no linearity there.
Like a change of behavior. Like in DID, all identities are within you. They're almost abandoning and like creating behaviorally, you're like literally taking on.
Okay, so you're on the right track. So, and this is a little bit of a problem that the APA really created for themselves in the use of vocabulary. So again, dissociative amnesia can be with or without fugue. A fugue state is defined by some travel and will often include an assumption of a new identity. And there's the I word. The individual with the new identity might change their job. It could be a pseudonym, but their psyche remains integrated. They don't switch back and forth between different personality states. That's dissociative identity disorder defined, which is considered to be a more severe form of what we're talking about in this continuum. With DID, the individual has an altered state of consciousness that takes over their awareness. That is not what's going on in the fugue state. That's different than saying, I'm AT, a mechanic from Sandusky, Ohio. So there's the difference. And unfortunately, the individual in that fugue state that it assumes that new job, for example, is hallmarked by a new identity, and that word confuses people because it's actually in the marker or the label for the more severe form of the illness, dissociative identity disorder, that itself is defined through an assumption of a completely different identity that takes over one's conscious awareness. None of which appears to be going on here, okay, but we certainly would inquire about it. Before we leave this aspect of Sydney Prescott, we mentioned electroconvulsive therapy, and I think on the shelf exam, it's probably worthwhile to review the 4 or 5 different conditions in which there's a primary indication for ECT. So what are the 4 or 5 scenarios presenting on a shelf exam for which a student will choose ECT as their single best answer? We already have one. Depression with psychosis. Here are about 3 others. All right, so let's say depression in which imminent danger, right? Because that includes suicidality too. And I wanted to bring that up because in this movie, largely because of the music, largely and specifically of Ploist or Cult, there seems to be some suicidal thoughts, right? So my point was that going down this path and case formulating Sidney Prescott the way we are, ECT does appear to be on the table now for multiple indications. The other indications include schizophrenia, usually schizophrenia, bipolar spectrum, catatonia of any cause, and then depression in pregnancy. Now, the clinical pearl is patient preference, so you always have to keep that in the back of your mind as a prescriber. So, severe depression, if the patient is provided a full informed consent, including alternatives to the SSRI, and thinks that, you know what, 90% success rate with fewer side effects sounds good to me, they should be referred to ECT.
Is ECT done in those under 18?
I don't know. I have to ask Dr. Ilaria that. Yeah. I think 16 is the cutoff in New Jersey, but I really do have to ask Dr. Ilaria. And there certainly is extra work to do if it is the case. That's a good question. I really don't know. I've never seen it done in anyone who is a non-adult. Other thoughts about Sidney from this perspective? All right. So I think switching perspectives to the third person and everything that we saw, maybe as an eyewitness, as observing her behavior, is pretty consistent with, I think, what we just reviewed. I mean, we see someone who's depressed, and even if we don't think that everything that happened is a product of her own mind, it's at least severe depression, especially if we do take Don't Fear the Reaper as some type of symbolism of Sidney's thoughts towards suicide. So I think we're pretty much in the same treatment plan.
Now, in terms of like differentiating our system and kind of like on the cusp of both in a way that I'm wondering how you differentiate what makes you say MDD.
Yeah, so I think in a clinical setting, so the question is, how do you really differentiate and evaluate for a major depressive episode beyond what we would consider persisting complex bereavement disorder? And I think it starts with the actual DSM diagnosis and seeing if Sidney Prescott meets 5 or more criteria. Movies rarely get this right, but again, I want to parallel that with shelf exams, right? Because in a single best answer environment, your case vignette may only give you 4, and the other 3 answers might be bunk. And there's no way anybody in here would ever consider leaving it blank and taking the attitude, no, it's 5, and that's just as wrong as, a somatoform disorder. You wouldn't do that. So we're going to apply that same type of test-taking strategy to movies as well. So even though Wes Craven doesn't give us 5 discrete symptoms, especially with the suicidality in place, we have to assume that there's some other symptoms here that are going to reach the criteria of 5. And that's where I was going with that. Any other thoughts about Sidney? But I want to jump to her mom, Maureen. So Maureen Reynolds, or formerly Maureen Reynolds, Maureen Prescott in the movie. It's a remarkable character because we never see her. And if you watch the entire franchise, we never see her. But arguably the most successful or the most popular horror franchise that exists in 2024 all emanates from this one character. So it's a remarkable character, incredibly complex character. What do we know about her? And I think after this discussion, I want to go back to Sidney just to complete our conversation, our case formulation on her. Right. So anything about Maureen we should know?
There's a lot of like social stigma around her, promiscuity, the way that people talk about her.
Mm-hmm. No doubt, right?
You have at least 2
At least, right? Right. Impulsivity. Right. So along those lines, I'm sorry.
The dad, boyfriend's dad.
Yeah, Billy's father, right? And Cotton Weary, who they frame, right? So there's at least 2, and If anybody wants to do it, feel free. You could jump on the wiki, and there might be even more. Right. So, what's our differential here in terms of this roundtable discussion? Oh. Maybe, right? Could be cluster B personality. Is there any other diagnostic criteria set that lists impulsivity and promiscuity?
In that?
Sorry? Erotomatic. So maybe delusional disorder, erotomatic type. Histrionic. So cluster B.
Yeah.
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 Yeah. I mean, that's something we have to consider here. Now, again, I don't want to over pathologize a character that we've never seen. However, she's dragged through the mud in this franchise, and I'm wondering if Wes Craven has this at least unconscious conflict that comes out in the sublimation as how we often demonize people with mental illness, right? And if that's the case, just to consider it, and it would be part of the routine H&P anyway. Does it shed light on what's going on with Sydney? Because if mom is bipolar, I think we have to actually discuss that in terms of Sydney Prescott as well.
She even said at one point to Tatum, like, I can admit now, I didn't want to
Realize mom.
Yeah, so those comments are supportive of that in terms of her the way she views mom. And again, in families, especially severe mental illness is often hidden. And the other part of it too, given what you had just mentioned about how she tends to idealize mom, this might be splitting. And it also might actually support your conspiracy theory in terms of everything being a product of Sydney's mind, because with especially Billy's character, if he's nothing but an imaginary friend, this takes on the evil stepmother motif, right? So in all these Disney films with evil stepmom, in the source material, Grimm's Tales, it's the biological mom that's still alive. And Disney twisted it with regard to the evil stepmother, and the reason why the evil stepmother is created is a function of splitting. So the individual, usually a young heroine, soon to be princess, Snow White, etc., has this evil stepmom, but in reality, it's an imaginary friend that imbues all of biological mom's negative attributes so that we can continue to idealize mom. Is that what's going on here?
It'd be interesting because it's also that scene in the bathroom, like, her talking like, oh, she made it all up, it's not really real, and that could be, like, if that were true, it would be a very interesting take on it.
So again, Wes Craven does provide us scenes that I think this might actually be supported. All right, so I wanted to just touch base on Maureen Prescott, consider bipolar illness, and if so, then we have to reflect that back. And by the way, in working up a major depressive episode for Sydney anyway, bipolar would be certainly a focus of clinical attention in as much as the APA requires us to investigate and rule it out before we actually rule in major depressive disorder. So we would have been there anyway. Final thoughts on this particular character, Sydney Prescott. Any other characters you want to talk about today? The answer is yes. So what characters?
Billy, maybe.
Yeah.
Billy? Okay. What do you got on Billy?
Maybe some elements of like void, a lack of empathy.
Mm-hmm. How surprised would you be if, upon Billy coming to clinical attention, it's revealed that these antisocial traits only manifest incident to the death of his mother? Would you be shocked or surprised?
Yeah.
You would be?
A tiny bit, because then that's, like, he's nearing 18. I would suspect some kind of like conflict disorder before this.
Mm-hmm.
Like, it would be a little bit strange. That's not, like, I wouldn't call it
Really? You think he did?
I would think so. I mean, they describe him as like kind of creepy anyway. Like, Randy is not a fan of him, and that tells me that like in the past there probably was at least some bullying and like some other stuff going on.
Yeah, well, I think we better keep this in a differential. You guys are tough.
Or like if he like maybe he could have like major depressive disorder with psychotic features like brought on by the like death of his.
Maybe when he's talking about like gutting and like what that was thing, he and Sue have a lot of knowledge about that and like engaged in some kind of behavior like
Maybe
that.
animal cruelty.
Even if it was like technically sanctioned.
Mhm. Got it. Okay. All right, convince me. Certainly, maybe not as a direct product of this, but maybe as a predisposing element, and certainly as a co-occurring illness. I think Billy is also grieving. Right now, again, remember Elizabeth Kubler-Ross initially posed her 5-stage theory, focusing on individuals who death and dying, who were suffering from malignancies and of course facing death. She later revised her theory to be applied to any form of loss, and that would include mom leaving home, mom leaving home, and beginning to case formulate Billy Loomis. What are those 5 stages? You have to go in order, because, and again, in her revision, she reminds us we don't have to go in order. So depression,
Bargaining,
anger, bargaining,
denial,
and acceptance, right? So let's rule acceptance out. I'm not sure Billy Loomis is at the acceptance stage just yet. What do you think's happening here with him? Yeah, I think that's pretty fair, right? Anger and then revenge. So Billy, I think his character and his case formulation, I think is a good, nice opportunity to review forms of grieving that are not the result of the death of a loved one, which is again exactly what Elizabeth Kubler-Ross revised her theory to focus on. So maybe he is depressed, and maybe his anger is manifest and certainly discharged towards the person that he blames. In therapy, what is something that you might discover that might even clarify this picture even more?
Maybe some abuse history.
So what about his father?
I think his father.
He's okay. Okay. Yeah. Where might you think anger is directed to if you were able to establish rapport with this particular character?
But does he blame her because he ended up
And I think that's my question.
Yeah.
I think there's displacement here because his superego is not allowing him to become consciously aware of who he's truly angry at. I'm not sure if it's mom or dad or both, but it's being cathexed or discharged to Sydney, and then we hear Maureen, not towards the people that have hurt him. But then again, I think in psychotherapy especially, we would anticipate this. Right? He's gonna actually displace that anger.
It'd be interesting if his reaction is grief and Sue was actually the one that because their first victim was like this is grief being manipulated by someone.
Yeah, and I think the dynamic between the two is ripe for discussion.
Yeah.
Because Stu is that other character that we certainly don't want to lose focus of, and I think might be even psychiatrically or psychologically richer than Billy himself, right? Because his first victim is his ex-girlfriend. And
Outside of Marine, I guess.
Right, I'm
Like
sorry.
we
You're
see
right.
in this
You're
one.
right. Yeah, and what role does he play here? So what do we know about Stu?
You know his parents are together because he makes that his parents are gonna kill him
Mhm.
because he had to go to jail.
Mhm.
He kind of has like
Yeah. Yes. Yep. He definitely does. If again, you could pick at his wiki, or we could just make it up. What part of his history do you think you might uncover if you were to provide a psychiatric evaluation on Stu? And I'm more not concerned or interested in his relationship with his parents. What is something that we would definitely be looking for here? And I know abuse, neglect, but I want more specific. And I think it falls right into what you're saying.
We're saying like specifically sexual abuse.
Yeah, I want to go along the lines of neglect. So again, huh?
If they are not at home, then no one seems to be checking in on him. Home is like literally destroyed.
And how might neglect impact what we see in this character? Can we connect those dots? And so it's histrionics, right? It's normal for a 4-year-old to walk into the middle of a room and start dancing.
Maybe like dependence to other people, like his dependence on approval.
Okay. Mm-hmm. Anything else? Stop thinking along the lines of the DSM. Think like a normal person.
It's more like an observation, but he's super touchy. Almost inappropriate.
Mm-hmm. I wouldn't be surprised.
Maybe like a disinhibited social engagement.
Interesting, yeah, could be. So, and again, I'm not going to pathologize people who are avid horror fans. That's not what I'm about to do. So there's my disclaimer. But the way he goes about talking about horror, you, as a viewer, you begin to question whether or not he's a little divorced from reality. Some of the things he does, some of the things he says, you wonder, does he think he's a character in a horror film? And that's Wes Craven, and that's what this movie is really about. It's that meta. But this character portrays that. He really does demonstrate this. And I'm just wondering how many times when he looked for his parents' approval, they were neglectful, and instead of answering him or attending to him, they sat him in front of a TV, turned it on, and said, "Here's your babysitter." Because at some point, he began to incorporate that, and I'm not so sure he's reality-based. I don't think he's psychotic. But I think a lot of his persona is absorbed from his early childhood experiences, and they may have been predominantly these horror movies that he's grown up watching. So I'm just wondering if there's something like that going on.
I mean, even when dying, the first question they asked him, did you really pray? And the smile.
Yeah.
Actually hear that.
Mm-hmm.
Come home.
Mm-hmm. All right, any other characters you want to discuss in Scream, or any of the topics you think related to this movie? All right, before we close, you're going to tell me the differential, or at least the different conditions that are part of the bipolar and related disorders chapter of the DSM. Preparing for our shelf exam. Bipolar 1. So what defines bipolar 1? Manic episode, right? Give me, with the exception of the direct influence of a substance or an underlying medical condition, which is always applicable, give me the one mental disorder that can be diagnosed in someone with mania other than bipolar 1. So if somebody presents, whether it's part of the HBI, whether it's part of the past psychiatric history when they were 14, with mania, they're bipolar 1, with this one rare exception. Yeah. Schizoaffective disorder, bipolar type, is the only mental disorder in which somebody can have an episode of mania and not be bipolar 1. Right? Otherwise, mania equals bipolar 1. How long is mania? Okay. And other than, again, schizoaffective, the effects of a substance or an underlying medical condition, there really is little else to consider in the differential as per the American Psychiatric Association. How does bipolar 1 separate from bipolar 2? Hypomania. And what is hypomania? It's less than 7 days.
Right.
7 days is that magic cutoff. And, yeah. And they have to have a major depressive episode. Exactly right. So it must alternate. That's not the case in mania. And that's not the case of bipolar 1. But in bipolar 2, A, it's hypomania. And B, those episodes of hypomania must alternate with episodes of major depressive disorder. That's exactly right. Hypomania, again, separates from mania, differentiates from mania, both quantitatively, it's less than 7 days, but more than 4, and qualitatively, and that it does not result in clinically significant distress or impairment. It's one of the very few illnesses that are defined through not being clinically significant. All right, what is cyclothymia or cyclothymic disorder?
First.
2 years, right? And how does minor depression differentiate from major depressive disorder?
It doesn't. It's not all 5.
Or that's persisting,
Oh.
or otherwise known as the Islamic disorder. No, you're close. I mean, you're giving an example of it. Is it? It's not clinically significant. It's similar to hypomania, right? It's not clinically. Minor depression does not cause clinically significant distress or impairment, right? So it's quantitatively, it's not 5, and qualitatively, it's not clinically significant. That's minor depression. And when minor depression or minor depressive episodes alternate with episodes of hypomania, we call that cyclothymic disorder, when in total it's at least 2 years. Treatment for bipolar 1, biopsychosocial, focusing on the biological or somatic therapies. So number 1, in the acute phase, we already say ECT. Okay. What else? With stabilizers. So give me some medication classes that would be considered mood stabilizers. That's one, right? So there's multiple antipsychotics that are FDA approved for not only the acute phase, and that could be either mania or depression, but the maintenance phase as well. What percentage of patients would you keep on maintenance therapy? Right. There's a 95% chance of a future mood episode that is of recurrence, and that means that 100% of your patients that you diagnose with bipolar, especially bipolar 1, will be maintained on that drug regimen for life. Right. So that's antipsychotics. There's one typical or conventional antipsychotic that is FDA approved. I don't know if this will come up on exams.
Quetiapine.
Quetiapine is the second generation. That's an atypical or second generation. It's chlorpromazine. I don't know if that'll come up in exams, just in case. Otherwise, the atypicals or second generations have multiple FDA approvals for bipolar. 2 more drug classes, or 1 more drug class, and then a single drug that's in a class by itself. Lithium. All right, lithium.
Antiepileptics.
And antiepileptic drugs, right? Okay. And again, similar, we're looking at these medications for the acute phase. That's either bipolar mania or bipolar depression, as well as maintenance therapy. Okay. What is your single best answer for bipolar depression other than electroconvulsive therapy? This is the one you're most likely to get asked because there are fewer antipsychotics FDA approved for bipolar depression than bipolar mania, or maintenance for that matter. Now, we tend to avoid all antidepressants. Always therapy. There's never a wrong answer. We're talking about pharmacotherapy here. Yeah, I think there's 2 or 3 antipsychotics. I'm almost sure quetiapine's one of them. Lithium is often used off-label. And it's interesting because the FDA didn't approve it, but the APA recommendations endorse it. So it's a little tricky, but I think that's fair game on a test. Lithium. So that, again, and then the other one that we often use is Lamictal, lamotrigine. So again, not an antipsychotic, but the antiepileptic. I think the best, the most robust literature looks at lamotrigine, that's Lamictal, as maintenance therapy because it is the one medication that tends to improve outcomes for future depressive episodes more than future manic episodes. Mm-hmm. Lithium's the opposite. Mm-hmm. What is rapid cycling? More specific? 4 or more episodes within 12 months. 4 or more episodes within 12 months. Somebody comes in, presents to you manic, and you find out they have a rapid cycling specifier. They are actually now having their 4th or more frequent episode in the past 12 months. Single best answer. Yeah. Valproic acid. Okay. If valproic acid is not provided in the answer set, the next best would be carbamazepine. Either or will be choices C or D. I will bet you, well, I can't bet you anything, but choice A is likely to be lithium. Skip it. Lithium tends to make the rapid cycling worse. Lithium could worsen mixed states. That is, discrete episodes that contain both depressive and manic symptoms made worse with lithium. Lithium can also worsen rapid cycling.
For individuals who develop bipolar like postpartum.
Yeah. And that often presents in the form of postpartum psychosis. Yeah. So usually we opt for the antipsychotic.
And also like lifetime.
That's not nearly as straightforward in the APA guidelines as what we're discussing. Certainly if there's a first degree relative with bipolar. So postpartum psychosis now is considered to be the uncovering of an occult bipolar illness brought upon by the trauma of childbirth. So I think if there's a first degree relative with established bipolar, you definitely will have a discussion about the mood stabilizer, whether it's an antipsychotic, whether it's outside the antipsychotic class, for life, maintained for life. Without that, the risk-benefit discussion is a little different. Final thoughts or questions? Screen. We're good? All right, we'll end it here. We'll post it on Twitter. Next week's film discussion is